Okay, this is a typical case for us. We presented this many years ago, and I think this is a nice case we picked today. Despite the fact that we give in pillow, this is a keratoconus patient, a lady who is now, you can see she's pseudophakic. She has a transplant that's over 20 years old. I think we've done this together, and you can see, number one, the pathogenesis of keratoconus, the fact that the inferior part of the graft, actually from here where I'm opening with my 15-degree blade, the graft host interface. So from the 10 o'clock position till the 4 o'clock position, there's dehiscence of the graft from the host cornea. And the reason for that is that her habits, the ones that created the keratoconus to begin with, which is sleeping on her eye, have not changed. So through the years, although this graft did very well, I'm using riboflavin Vibex Extra here by what used to be Avidra, and now it's glucose. I've opened the graft host interface. I'm going to resuture almost half of the graft. We've checked the cell count is good. The cornea topography can be elusive, cornea tomography rather, with the pentacam, because it shows all the area that we opened that's steepened, and it creates a lot of astigmatism at that point. So it's a key thing for clinicians not to get tricked and treat this on the graft, because it will only make things worse. This is not astigmatism from pull or change in the graft host interface. This is astigmatism for dehiscence and from actually the area that we were suturing bulging out. So you guessed it, we're using riboflavin as a prelude, because we're going to finish this with CXL. We're going to use 30 milliwatts per centimeter square for a total of 7.2 joules, for so higher energy than the classic Dresden protocol. But we opened the box of using higher fluence back in 2005, and everybody has followed suit. In this particular case, I think it will help reinforce mainly the host cornea inferiorly that has been weakened from eye rubbing. Obviously, we will give also a mask that we've also posted on YouTube, a make it yourself mask that is two soft sleeping masks that encase a eye shield, and patients can sleep well. Usually keratoconus patients sleep face down on one of their hands or both of their hands. We're seeing here how careful I am. Go deep but not through the graft, and deep but not through on the host. The long bites, because I want to reinforce the stretching that her own cornea, the host rim of the cornea, has undergone through all these years from the continued eye rubbing. The patient obviously has floppy eyelid syndrome and all the associated things with keratoconus. Obviously, there's no um, big lesson to be learned here. These are classic sutures for any cornea transplant surgeon. So we are just making sutures that are tight, not super tight. Obviously, as you go along, some of the initial sutures may seem to be looser because we're actually reshaping, and this is the procedure that we're trying to do, the inferior part, mostly inferior nasal part of this graft, because of what the wear and tear has gone through these years. Surprisingly, all these years later, the graft cell count is good. And obviously, many colleagues will, cornea specialists will go and redo a graft in these circumstances. I'm not sure that's the best choice. Obviously, this is a problem for us here in Greece, as the cost to the patient for a cornea tissue that invariably comes from the U.S. Is close to $4,000, not to add all the rest. And this is a procedure done in the office, quite simple. I've used in this particular patient peribulbar anesthesia, but you can do this on topical. There's very little discomfort for the patient. This particular patient was quite anxious, very nice lady. We wanted to make sure that she's also very comfortable. We saw that used pilocarpine 2 or 3 times due to the dilatation that happened with the peribulbar anesthesia. We used pilo prior to the anesthesia. You have to be very careful in keratoconus in lieu of the Uretz-Zavalia syndrome. We don't want to end up with successful procedure and a pupil stuck, open, dilated. essentially done. Re-putting riboflavin extra in the wound. Cornea is well soaked, and we'll jump to our KXL1 device to perform the cross-linking and finish our procedure that way. Thanks very much for your attention. This is John Kanellopoulos from our Ambulatory Surgery Center here in Athens, Greece, signing out.